So,
आप ये बताएं दिल्ली में रहती कब है?
हाँ नहीं,
मैडम,
I meant Trichy
आप
actually.
दिल्ली में रहती कब है? आप तो आधे टाइम तो बाहर ही रहती है। अब
All Saturdays
इंटरनेशनल
and
विजिट्स
Sunday
आपकी
Preeti
ऐसी चल
ma'am.
रही है, नेशनल मतलब मेरे ख्याल से तो आप इसी से लगे हुई है।
Oh, you are right. I never thought about it anyway.
Shall we start, sir?
पर आपको देख के कभी ऐसा लगता नहीं है कि आप इतना वो है, आप हमेशा इतनी फ्रेश लगती है कि हमको तो लगता है कि यार कैसे क्या एनर्जी लेवल और क्या है।
I think it's a routine for you, ma'am.
Yeah.
Gajan sir, shall we start?
Yeah.
मेरे ख्याल से ये सरजनी मैडम भी हैं, सब कोई है तो
yes.
कर लेना चाहिए
Okay.
क्योंकि मैडम को
Yes,
Yeah,
yes, we can.
otherwise she'll be getting late now. So, good afternoon, everyone, and I welcome you all for our third online master class in Gurukul. Today's topic is corneal edema, and as you all know that it is designed in the interest of postgraduates and comprehensive ophthalmologists. We had a very good discussion during our last two sessions, and now in the same series, we have today a very eminent speaker today, Dr. Namrata Scientific Committee AIIMS. We welcome you, ma'am. Now I welcome our session officials, Dr. Sharadini Vyas, a very eminent corneal surgeon. Recently she joined School of Excellence Indore. Dr. Pankaj Chaudhary, Professor, SS Medical College, Rewa. Dr. Rahul Agarwal, Professor and Head, Allen Medical College. Dr. Gautam Parmar, Consultant Cornea and Refractive Surgeries, SNC Chitrapur. Then our postgraduates, Dr. Nikita from Gandhi Medical College, Dr. Tanisha Mittal, SS Medical College, Rewa, Dr. Radhika Maheshwari, Aurobindo Medical College, Indore, and Dr. Nitika from Arcadius Medical College. I welcome you on behalf of Bhopal Divisional Ophthalmic Society for this third session of Gurukul. Now I invite our President, Dr. Gajen Chawla, sir.
Good afternoon, everyone, and welcome to our guest speaker. I should say guest speaker, our own speaker, because I consider Namrata Madam is a part of our Bhopal Divisional Ophthalmic Society. Maybe she's a representing All India and for a couple of years, but she's so familiar with us and she always consider us as a family member. So I welcome to, Dr. Namrata Madam for today's episode. As Dr. Vasudha says, this is an initiative from Bhopal Divisional Ophthalmic Society to upgrade knowledge of ourselves as well as our postgraduates. It's a master class and it is a third in the row, and it was a great experience in the previous two classes. And I'm very happy to share that this particular class, initially when we designed, we thought of for Bhopal Divisional Ophthalmic Society. But is the interest from the other divisional society of our state has also shown. So we have extended this to the MP state now. Share this particular flyer and the information to different groups in earlier in this week. Some people from out of MP has also inquired and asked me, can we join and this? So I'm very happy. Even it is only the third episode of our Gurukul class, the master class. The people are taking interest and it is creating interest in the PGs and the general ophthalmologists. And I think it is only because of our guest speakers like Namrata ma'am and the earlier speaker, Dr. Umang Mathur and Vanati madam, who has taken our master classes. And I'm sure if we'll try our best, and I assure from the team of BDOs, if we'll try to get such eminent speaker with us in future also, so that these classes should this benefit should pass to the our PGs and the general ophthalmologists. I welcome you, ma'am, and all other speakers. And as I know, Namrata madam is very busy and she has spared time from Trichy. She is busy with some conference there and she agreed to spare time for us. So on the bottom of my heart, again, thanks, ma'am. And without wasting your time, we'll invite you for your class. Before that, Dr. Vasudha, please take over.
Yes. Now, we all first, but just to share a brief introduction about her. She is working as Professor Cornea and Cataract and Refractive Surgeries in RP Center, AIIMS Delhi. She has done fellowship from Moorfield Eye Institute in London, UK, and she served as Honorary General Secretary of AIOS and Eye Bank Association of India, as the Vice President, Cornea Society of India and National Society for Prevention of Blindness. She also served as Regional Secretary, Asia Pacific Academy of Ophthalmology, and has 2 patents in her name, Netasol and Netametrix. She is brand ambassador for TFL and Ocular Surface Society in India, and having many international awards in her account. One of the 1,000 Indian scientists in the list of top 2% scientists in the world by the list of 100 top powerful women ophthalmologists in the world. Senior Achievement Award from American Academy of Ophthalmology, Ophthalmology Education Award. This award is 6 times by AAO and award at AAO. She holds 570 publications in international peer-reviewed journals, authored more than 17 books, and part of many international multi-risk FDA trials. So this is all about her. In person, whatever I can say, that she is the finest human being I ever met. Very simple, very humble, and down to earth. Ma'am, we welcome you on behalf of Bhopal Divisional Ophthalmic Society, and I request you to start your talk.
Thank you so much, Vasudha, and I would like to thank the Madhya Pradesh State Ophthalmic Society for giving me this opportunity, and also Dr. Gajendra for this invitation. I always feel at home in MP State Ophthalmic Society because that is also the state where I have been coming since my postgraduate days with Professor Rasik Vajpayee, and that is also his state from where he came. So I would be talking to you about phacoemulsification, and one of the important complications that can happen after phacoemulsification, and that is corneal edema. And I think this is something which can happen to anybody, and one should know how to manage it. So the causes for post-phacoemulsification corneal edema could be preoperative, such as loose Descemet's membrane, Fuchs dystrophy, PPMD, familial or anatomical propensity, such as big H3 proteins. And the clinical implication of this is that preoperative counseling of these patients have to be done with careful surgical planning. So if you know that the patient has a loose Descemet's membrane, scleral tunnel and superior corneal incisions are to be avoided because inferior DMDs are more difficult to treat than superior DMDs. So it is better that in these cases you don't do temporal incisions. Then intraoperative factors could be surgical or could be pharmacological trauma, and post-operative factors could be topical drugs, post-herpetic endothelitis, which are again 2 important causes of corneal edema occurring after phacoemulsification. So Descemet's membrane detachment is one of the most important causes that can occur because of the surgery. The incidence varies. So even after phacosurgery, incidence is from 0.04 to 0.5%. And gonioscopically, it is higher, and it is possible that these DMDs are not seen. The intraoperative factors are also several. So it occurs more with clear corneal incision, shallow anterior chamber. It occurs less with femto incisions, more if blunt keratomes have been used or shelved or anteriorly placed incisions are there, or if there's inadvertent injection of saline viscoelastic, which is happening during any of the steps, which include irrigation, aspiration, stromal hydration, or during IOL placement. And when the total ultrasound power is more than 60 seconds, then also the chances of this increase. So it is important to do a good slit lamp evaluation, and sometimes you can see it as a translucent layer. Topical glycerin needs to be put to dehydrate the cornea. You can have corneal edema or double anterior chamber. Visualization is generally not possible because of corneal edema. The stormy post-operative course is there. And gonioscopy, of course, you will not do after a surgery, but you can see small peripheral detachments. The investigations that are required are ultrasound biomicroscopy, which may or may not be available at all centers. But it is important to do anterior segment OCT because that adds to the diagnostic value by 30%. It determines the site configuration and the extent of DMD and guides the treatment method and also monitors the treatment outcome. So it is important to know the morphology because the planar DMDs, which are less than 1 millimeter separation, have a better prognosis than non-planar DMDs, which have more than 1 millimeter separation. Then you should know whether it is central, peripheral, or combined, whether it is superior or inferior, with or without scrolled edges. And also the classification has been given, which could be rheumatogenic, tractional, bullous, or it could be complex. So for non-scroll desmet membrane detachments which are localized, some of the small ones will undergo spontaneous resolution, and there'll be resolution of the corneal edema also. But spontaneous reattachment of desmet membrane and migration of the endothelial cells has also been described. The waiting period is generally 2 to 3 months, and for these cases, generally topical steroids, topical hyperosmotics are given, along with sodium chloride 5% drops 4 to 6 times a day, and sodium chloride ointment at bedtime. Cycloplegics and anti-glaucoma medications can be given if required. Now, there have been various agents which can have been injected for the desmet membrane tamponade, which could be air, SF6, or perfluoropropane, 12 to 14%. And post-operative posturing for gas bubble tamponade is important. Now, this case was in fact referred to us for corneal transplantation or DSEC. We did an anterior segment OCT to see the scrolled edges like this. And it is important that when you are doing a gas tamponade in such cases, you should not inject the air from the red arrow because that will increase the scroll, but from the green arrow because that will cause the apposition of the desmet membrane. So when we did inject the SF6 gas, this is how post-op picture was, and we deferred a corneal transplantation procedure. This is just to show the steps of how to manage. This is a sectoral corneal edema. You pilocarponize the pupil first, take a 30-gauge needle on a tuberculin syringe, and try to get in one bolus, one single bubble. So again, this is the air which is being injected. So once you get that, you have to get the needle out. Now, important thing is if the needle is out, the bubble may also come out. So I think that is something which has to be avoided. On the table itself, you can see that this part of the edema which is there will clear up right before your eyes. And first, put a pressure with a swab stick there and then get the needles out slowly so that the bubble doesn't burp out with your ejection of the needle. Now, this is just to show how important thing is you watch this, and then I will tell you the correlation here. So we've injected an air bubble. If you watch only this, we think the desmet is attached, but it is not attached, as can be seen here on the intraop OCT microscope. But notice as you do external massage, as the cornea clears on the table itself, and you inject an air bubble again, the desmets will become attached. So the key points on the operating microscope are that you do the external massage, you inject the air bubble or the gas, and then you see the cornea actually clearing on the table itself. So that will be the endpoint for your management of desmet membrane detachment. Now, this is just to show a few cases of MDs, which do happen inadvertently. For instance, here you can see that there's a desmet membrane detachment here. So as soon as you see it here, important thing is that you put an air bubble in such a manner at the end of the case so that the desmet actually covers up the area of the detachment. It should not go the other way around because when you're injecting the air, it can go the other way around also so that the flap becomes more enhanced. That should not happen. This is yet another case again where the desmet membrane detachment is there, and you can pick it up on the wound site. You can see that here there is a small desmet membrane detachment, but you can't see it here because of the hydration. But suppose you are able to see it here, then it is important that you inject air bubble at the end of the surgery, and again see that the descemet is attached and it is not getting detached, but it is folded in the correct direction. That is also important. Now here it's a loose descemet membrane which can be seen here and can be seen here also. Again, when you close the case, put a air bubble there. And once you put a air bubble there, the descemets will come attached. Now this was a case of descemet membrane detachment operated outside, which was referred to us. And you can see that here it is quite taut. Now these cases are very difficult to treat. It is also kind of broken. So when you are putting the air bubble, you have to see that there is no gap between this broken descemet membrane and it is attached. It doesn't matter if there are small folds present. I can see it here, but maybe you can't see it here. Because what will eventually happen is that the endothelial cells migrate and they cover it up. This is yet another case where again, you can notice that there is a descemet membrane detachment which is leading to sectoral corneal edema. Again, in this case, you inject the gas there. This was again a referred case. And once you put a gas or inject the gas, notice how it is trying to come out of this wound side. So again, you have to be careful when this needle comes out because you don't want the air bubble or the gas coming out with it. Give external massage. Once you give external massage, this will become clear. And as this gets clear, this will also get attached here. So the end point is the clarity of the cornea when you are actually doing these when you are addressing these descemet membrane detachments. This was a case of a post-direct descemet membrane detachment. Nothing great here except that again in this case we injected gas here, and this will get attached, but the pressures will become high after about 5 to 6 minutes. Whenever you feel the pressure is high, you burp up that bubble. And again, notice again, I have been pointing and highlighting on the table itself. If you put that pressure for some time on the table itself, it will clear without having to look at it on the OCT. This was our publication of algorithm for descemet membrane detachment to manage after intraocular surgery. We took 37 consecutive cases of persistent corneal edema, which were referred to us within 4 weeks of cataract surgery. And I feel even if it is within 8 weeks, it doesn't matter. So the first thing that you have to run and do is do anterior segment OCT. And if there is descemet membrane detachment, like in this case, almost 3/4 of the cases or 2/3 of the cases had descemet membrane detachment, they will resolve with air or gas injection, and you will defer a corneal transplantation or endothelial keratoplasty in these cases. So this is the algorithm that we derived from the study. So if there is a DMD which is there, which you see in the superior half, and if it is planar, then you have to inject air. But if it is in the superior half with scrolled edges, or if it is in the inferior half, whether planar or scrolled, you have to inject intracameral SF6 or C3F8. So when to inject air or when to inject gas, this is the algorithm for that. If it is planar, then intracameral air in the superior half. But if it is scrolled edges in the superior half or in the inferior half, whether planar or scrolled, SF6 or C3F8 should be instilled. This is just to show some of our cases pre and post-op. When you inject the gas, they do, the descemet membrane becomes attached. The corneal thickness does become okay. Sometimes what happens is that the descemet membrane is very taut, like in this case. And it is so taut that two rebubbles which are done in this case did not suffice. So what do we do in such cases? You look at the anterior segment OCT. If it is really taut and that gap remains, the SF6 is being injected, and maintain this pressure and put a suture. You put a suture here so that the approximation of the descemet membrane will be done. And again, notice the endpoint is the same. It becomes clear. As soon as it becomes clear, you know that the descemet membrane is pretty much attached, and then you can leave it like this. And the positive pressure is consistent here. Your assistant is putting a positive pressure so that the descemet comes towards the stromal layers and it doesn't move away. And again, as soon as you put pressure there and the needle comes out, and again put pressure so that your gas doesn't escape out. Repeat desmetopexy may also be required in some of the cases, this as has been published, and show the same case, persistent corneal edema for 1 week, and we saw that there is a small Descemet's membrane detachment there which is causing it, and then we had to rebubble 3 times. So do not give up on rebubbling. You may have to do it once, it will become less, but it will be still there. Do it again, it becomes less, it will be still there, and do it a 3rd time, it will be there. So sometimes you have to do multiple injections to sort this thing, and this is just to show the same. So if you see in this picture, it is still there after a rebubble, and we rebubbled again, it's gone. So this is what we published, and these are practical problems because people ask how many times can you do it, whether you should immediately refer for endothelial keratoplasty or can you sort it out. The second thing that I would want to talk to you about is the incision site DMD during and after phacoemulsification risk factors in management. As we are making these patients, there's DMDs at the wound site, whether at the main wound or the side port. So this was a study of 103 patients. And we did intraop OCT, we did anterior segment OCT on day 1, day 7. And we found that 14 of these 103 cases, that means almost 14%, had a DMD also on day 1. But all cases, they resolved by 1 month. So wound side DMDs may be present on day 1 or 1 week, but they do resolve over a period of time. And the factors which were responsible for this were increasing age, increasing grade of nuclear hardness, and higher energy that was used during phacoemulsification. So this is just to compare femto wounds versus conventional wounds, and we found that in femto wounds, the DMD was 9% as opposed to conventional wounds where it was 49%. This was, of course, on an intraoperative OCT microscope. So these figures are going to be high because this is what was deciphered on the operation table. Now, the second thing I want to talk about is the herpetic endothelitis after phacoemulsification. Now, this is a case which doesn't have a DMD. So we gave a trial of acyclovir, and this case clears up like this. So sometimes all that you require to do is just give a trial of acyclovir, and if there's a herpetic endothelitis which has got aggravated after phacoemulsification, after acyclovir and topical steroids, systemic acyclovir and topical steroids, it clears up like this. This is yet another case which was referred for corneal transplantation. Again, here it was felt that it is herpetic endothelitis where which has, aggravated after phaco. And we gave a trial of acyclovir. So on medical therapy itself, on acyclovir and topical steroids, this has cleared up. This is yet another case of herpetic endothelitis after phaco, which clears up. And this is what we've published. We have several more cases now after 2006 where we give topical steroids, topical and systemic acyclovir, and it clears up because it is not due to DMD, it is not due to corneal decompensation, but it is endothelial cell loss, but it is due to herpetic endothelitis. So this is what I was talking about. Tablet acyclovir 400 milligram 5 times a day for 21 days with topical steroids. Of course, if all else fails, then what we would require is an endothelial keratoplasty. Now you have to know where it can be done and where it cannot be done. So for cases like this, you can do it because your stroma is not scarred. And in such cases, I think cornea surgeons would help to correlate with this, that a stromal lenticule is taken with Descemet's membrane and endothelium. And this is then loaded onto the Busen's glide, and after doing desmetorexis and removing the injured or the compromised Descemet's membrane, this is intracamerally pulled, and then subsequently air bubble is instilled here so that the DSEG graft gets opposed to the back of the cornea, and this may be required, especially when the endothelial cell failure is there, which could be also because of the preoperative factors that I have shown you before, some of them congenital, some of them due to PPMD or to Fuchs dystrophy. Of course, the most physiological procedure for such cases is DMEC, where the desmetorexis is being done here, followed by the followed by the Descemet membrane roll, which is being fashioned. And this is the diseased Descemet membrane, which is removed. Descemet membrane roll, which is a physiological graft with healthy cells, which is taken. And this is then instilled intracapillary. Now, how do you know which side is up? So you have to look at this configuration, which is shown here. The biceps curl upwards. So biceps always curl upwards. So you have to get that sort of a configuration here. So it's upside down here. You can see it is upside down. So we are putting some more fluid so that the whole graft shifts to the other side. Now this is the correct configuration. And when you have that biceps curl upwards, it means that the endothelial side is facing down. This air bubble is instilled, so the graft is touching the back of the cornea. So this was the case which was there at week 1, and this was the post-op picture at month 1. You can't even make out that there's a Descemet membrane graft there. Very carefully, if you look on the slit lamp, then you can see that there is a Descemet membrane graft there. Now, this I want to show you because this case was referred to us. The surgeon was doing a phacoemulsification. And as the surgeon was doing a phacoemulsification, the whole Descemet membrane in a scroll came out like this. So this is just a simulation that I'm showing you. And this is, of course, not the real case, but I'm anticipating that this is what would have happened. It came out. So the surgeon just put it back again and referred the case to us. 2 hours later, we saw this case. This is how the case looked actually. And we didn't know which side was up. So we did have this intraop OCT microscope. So again, we tried to see which side is up by looking at the biceps curl configuration. And I call it autodemet because it is the patient's own Descemet membrane, which is in the form of a disc, which has got detached and is there inside. But which side is up has to be seen. Again, you get it into the configuration of biceps curl upwards and you inject air bubble. And now this is pretty much attached here. Collagen cross-linking is another thing which has been described for persistent corneal edema, and we did do a study, retrospective one in 50 eyes of pseudophakic bullous keratopathy who underwent collagen cross-linking. The pain score did decrease, the corneal thickness did decrease, the best corrected visual acuity did improve, but it came back again. So this was a procedure we realized only for the interim period when the patient is not undergoing an endothelial keratoplasty. And it does temporarily improve pain, but does not provide long-term improvement in best corrected visual acuity. So this is just to show the pictures from the R study. This is pseudophakic bullous keratopathy. You do collagen cross-linking, it clears up. And then another case of this is 1 month, 3 months, but notice at 6 months, it has come back again. So you are probably worse off as compared to what you were before. It would relieve symptoms, but I feel it causes a little more scarring. And these cases may become unsuitable for endothelial keratoplasty, so it is best not to do it. I'm sure the next treatment that is going to be there in future is going to be in the form of pharmacological treatment, the ROCK inhibitors, the Rho kinase inhibitors, which help in regeneration of the corneal endothelial monolayer. And this is the study which has been done by Dr. Kinoshita's group, where they are using ROCK inhibitors. In our country, we have 2 ROCK inhibitors, the Ripatec and the Nitolo, with no financial interest or proprietary interest in any of them. But they do help to pump up the endothelium a little bit. And in cases, apart from giving sodium chloride, 5% and ointment sodium chloride, I also add Ripatec or Nitolo. But the flip side is that it is going to cause some amount of congestion. So again, patient has to be warned about that. Now, this is something which Dr. Kinoshita's group worked at, and they have been quite successful. And that is, they take the endothelial cells, they culture it, and they inject it intracamerally, and the patient has to be there in the prone position for quite some time. So this is something which has been done, and these are again the pictures from his study, the injection of the agents, and then how the patient, when he's in the prone position, how it is going to be. So these were the pictures which were published in New England Journal of Medicine. These are cases of corneal edema, and they clear up after injection of the endothelial cells plus the use of the ROCK inhibitors. So this is the algorithm that I would say is for corneal edema. Whenever there is a post-phacoemulsification corneal edema in the immediate post-op period, give topical steroids, topical antibiotics. I would add ROCK inhibitors also in this, anti-glaucoma medications, and sodium chloride drops ointment. If it responds, it's well and good. If there is no response, always in these cases, also do a anterior segment OCT, which should also be done in cases of persistent corneal edema. And if you ask me, how long can this membrane remain detached before it get attached by a air or a gas injection, I would say the limit is 8 weeks. So if there is a DMD even up to 8 weeks, please do not avoid giving a trial of injection of air or gas, because it does help. I have seen cases even up to 12 weeks where DMDs have responded. The corneas may not be pristine, clear, absolutely like a 6/6, but they do get about 6/12, and that is good enough for them. So if there is a DMD which is present, desmetopexy, which I have shown you, but if there is a DMD which is absent, always before registering the patients for endothelial keratoplasty, do give a trial of acyclovir, suspect hepatic endothelitis, and so systemic acyclovir and topical steroids may again defer endothelial keratoplasty, because that is what our aim is, especially if you've done a cataract surgery and you don't want the patient to undergo a corneal transplant surgery in these cases. So moving now. So ROCK inhibitors is then something which I have now amalgamated into this algorithm. This is a publication on corneal edema after phacoemulsification, which is, if I put it on the PubMed, I think it is the most cited publication which has appeared in Indian Journal of Ophthalmology, the management of corneal edema after phacoemulsification. And this is our review article on desmoid membrane detachment in survey of ophthalmology. So to conclude, persistent edema can occur after phaco. Slit lamp exam and anterior segment OCT should be done in all cases. If DMD is present, pneumodesmetopexy should be done. Hepatic endothelitis may be suspected if it doesn't resolve. EK after 3 months on resolution of DMD, and pharmacological therapy may replace endothelial keratoplasty in future. Thank you very much for your kind attention.
Thank you so much, ma'am, for a nice presentation. And now I invite our postgraduates for questions. And Dr. Sharadini, ma'am, we have got very eminent panelists today, Dr. Pankaj, Dr. Rahul, and Namrata, ma'am. If you can spare some more time, Dr. Gautam Parmar has also joined.
Yes.
So now where is Dr. Nikita? You can go with the questions. Dr. Nikita Srivastav, there are questions in the chat box.
Good afternoon, respected sir and ma'am.
Yes,
Dr.
yes.
Nitika has asked difference between herpetic endothelitis and deciform keratitis.
So I think that's a different question, but hepatic endothelitis would have desmoid membrane folds, may have anterior chamber cells also. Whereas disciform lesion will not have. Disciform will be more point-shaped kind of a lesion, and hepatic endothelitis may or may not be point-shaped. It may involve it completely or sectorally. Tends to be a little, sectoral or triangular first, or if the entire thing is involved, then it may diffusely involve the whole of the endothelium. But it will not have, unlike a disciform case, it will not have clear-cut margins like a disciform keratitis would have.
One more question. Will we get stromal edema along with this in herpetic endothelitis?
Yeah, you will get stromal edema with it. If you do the corneal thickness, it would be increased.
But not like typical disciform keratitis, as otherwise we get in viral keratitis.
Yes.
And how frequently you notice this endothelitis in cases of post-phaco corneal edema?
It's not very common. I'm not saying that it is very common, but
okay.
I think you have to keep it at the back of the mind. That you give a trial of acyclovir if you're suspecting it, and if you see that there is no desmoid membrane detachment, and if you see that there is no reason. It was an uncomplicated kind of a phacoemulsification surgery, or if there has been a time when following phacoemulsification, patient had good vision and suddenly the vision has deteriorated in the immediate post-op period. So then in these cases, you should keep a suspicion of it.
The non-responding corneal edema, this could be one of the reasons if we don't find post-desmoglein detachment.
Dr. Namrata, can I ask one question?
Yeah, surely, ma'am.
Sorry, I mean, I should not, but for the postgraduate, can you clinically tell us that the cornea gutata grade 1, 2, 3, 4? So when do we decide for two-step treatment and when we do a combined surgery?
So there is a classification for cornea data which is there, grade 1, grade 2, grade 3, and grade 4. Although it is, you can say it, I feel, if you ask me, I feel it's a theoretical classification only. And there is always a question whenever there is a case of Fuchs dystrophy, whether should you do a combined procedure or should you do a phacoemulsification first, or should you do a endothelial graft first? And the answer is always that everything depends on the visualization of the cornea. If you can visualize the cornea and there is a cataract also present, I would always do a cataract surgery first and see how it goes. And then for anterior keratoplasty if it is required. And for me, if the cells are less than 800 and if the visualization is poor, or if the visualization is poor and the corneal thickness is more than 680 microns, then I would do a combined surgery. But if the visualization is good, then in all those cases of Fuchs dystrophy, despite the fact that I can see the gutata and gutata are there, I would still do a phacoemulsification surgery under with no financial interest in viscoat also. The only thing is that it protects the endothelium well because it has chondroitin sulfate. So do that first under viscoat cover. And I know of cases who have remained in the post-operative period like this only with gutata, but they have not deteriorated. I'm sure the endothelial cells loss would have been there even after cataract surgery, but they have not deteriorated in the sense that their best corrected visual acuity has not been compromised. So for me, always when Fuchs dystrophy is there with cataract surgery, it's almost always a sequential procedure. I do a endothelial keratoplasty only when I'm forced to after a cataract surgery.
Right. Do you start Ripatec or Metaxavir immediate post-op? Or do you wait
I would start Ripatec even pre-operatively. Torcetrol, I have tried much, so that is why only in very few cases, but Ripatec is something which I've tried in many cases now. Of course, the flip side of these drugs, and I think our glaucoma people are very well aware, is that sometimes they have that epithelial edema if you use them for a prolonged period of time. So that has to be kept in mind, but that would start before the surgery and that would also continue after the surgery for at least 6 weeks.
And what about PPD cases? You go ahead with the cataract most of the time?
PPD cases, posterior polymorphous dystrophy cases, also my algorithm would remain the same. Do a cataract first and then only take a call on the, because the problem is that once you do a graft, that doesn't happen for endothelial keratoplasty or for DMAC grafts. But once you do a graft, then your story starts there. It doesn't end there. But once you do a cataract, your story ends there. So, there are two different things. Once the graft is there, then it's almost, patient has to follow up almost lifelong.
Nitika, any more questions in our chat box?
Dr. Tanisha want to ask. Tanisha, you can ask directly.
Yes, you can. You start your video also.
Dr. Tanisha.
Good afternoon, sir. Good afternoon, ma'am.
Yes.
Thank you, ma'am, for such an informative lecture, ma'am. My question, ma'am, in case a patient is having cataract and as well as Fuchs endothelial dystrophy, then which surgery should we do first? For cataract surgery or Fuchs endothelial dystrophy? Surgery karna chahiye.
I think we have covered this.
Ma'am, one more question. In herpetic endothelitis, should we give topical or systemic antiviral both or only systemic antiviral?
Ma'am, you are muted. Namrata ma'am,
Yeah.
you are muted right now.
So for herpetic enterocolitis, we would like to give systemic acyclovir only. Topical, we actually add only when there is an epithelial component to it. But, and we give topical steroids. We don't give topical for herpetic enterocolitis.
Ma'am, one more question can I ask?
Yes, please.
Ma'am, how to differentiate dystrophy-induced corneal edema and glaucoma-induced corneal edema?
Sorry, how to differentiate?
Yes.
Dystrophy-induced corneal edema and glaucoma-induced corneal edema.
A pattern of corneal edema she wants to know in dystrophy or maybe because of raised diabetes. This is what you want to know, right?
Yes, ma'am.
In Fuchs dystrophy, the corneal edema is not going to be there in the initial stages. Of course, whenever you have corneal edema, you can. You mean between dystrophy and between viral cases or
Glaucoma.
Glaucoma
cases?
edema because of raised IOP. Glaucoma.
Okay, edema because of raised IOP. So I think that's a very clever question. Because of raised IOP, if you see the corneas, they tend to, whenever you raise the IOP, they tend to actually clear up. They look all the grafts, when you see the grafts on the post-operative day 1, and if they're looking exceptionally clear, then you think your pressures are high and that is why they're looking so clear. If it is a corneal edema due to Fuchs dystrophy, for instance, the cornea is going to look very hazy and the corneal thickness would also increase. If it is a corneal scar, then the corneal thickness would be decreased. It will be thinned out cornea. If it is corneal edema, which is there because of glaucoma, then the corneal thickness would be increased. With Fuchs dystrophy, you will see other features also. For instance, if it is a Fuchs dystrophy, you will see guttata, which will be present, which will not be there in a corneal edema due to glaucoma. So you can always look at the fellow eye also in such cases, because that also helps. The fellow eye, the pressure is not raised, and or if the fellow eye has guttata which are present, then you know that it is most likely due to Fuchs. And Fuchs dystrophy will not give you a sky-high kind of a raised intraocular pressure, which will happen, once the pressure is raised. With Fuchs dystrophy, the pressures are going to be, or whenever the edema is there, the pressures are not, maximum they'll go into 30s. But with glaucoma, your pressures are going to be sky-high.
Thank you, ma'am.
There is one question that carbonic anhydrase inhibitor, are they to be avoided in cases of post-keratoplasty cases or endothelial dystrophies or dysfunctions?
So only
Use of
drugs,
carbonic anhydrase.
yeah, so the only drugs that you avoid in cases of grafts, etc., is the prostaglandin inhibitors. You don't avoid carbonic anhydrase inhibitors because that causes uveitis. So those prostaglandin like Travatan or like Megan, etc., you would alpha-gun, you would try to avoid in cases where you've done grafts because that will cause uveitis. Otherwise, you don't avoid any kind of drugs.
But no contraindication for carbonic anhydrase inhibitors and endothelial dysfunction?
There is no contraindication. You can give it.
Okay.
Ma'am, you said,
Yes, Dr. Pankaj.
ma'am, you said for DM stripping, maximum 8 weeks can be taken care of. So what is the upper maximum limit we can take care of this DM stripping if they are coming after 3 months or later on? Do we reposit it or not?
No, so even at 3 months, I would reposit it, but then also you have to look at the corneal thickness. Now, even if you reposit and the corneal thickness is say 900 microns, then the pump may not function. So your baseline corneal thickness is also important. If your baseline corneal thickness is say 600, 700 or 750 microns, if it is say 3 months old, I would still go and inject. And anyway, these cases are undergoing endothelial keratoplasty. So if you give one trial of injection of air or one trial injection of gas, it doesn't matter.
Okay. Thank you.
Dr. Parmar, your comment?
Thank you so much, ma'am, for the opportunity. I just have a question regarding the Descemet's membrane detachment, because what we have sometimes seen that the Descemet's membrane detachment is not a unidirectional. Am I audible to you, ma'am?
Yes, yes,
Yes,
yes.
yes.
It is not a unidirectional, means it's detached from the periphery and come to the center. I think that is very easy to reposit, but sometimes what happens, ma'am, it splits from the center, even in a still manner. Multiple flaps are there, one flap going down, one flap going up. So sometimes we find difficult to oppose it. So is there any thing we should take care of it when it is split, multiple split?
There are multiple spreads, or when it is going and it's a tri-radiate kind of a thing, like a star in different direction, then I think you have to then do it simultaneously, in the sense then I would make two side ports, one on the one on the left. And from one side, you would inject through it so that all those radiations which are flapping in the anterior chamber, they kind of try to go towards the stromal layers. And from the other side, you inject the air. So it's like a air fluid exchange that you have in retina. You try to do air fluid exchange for those radiating, Descemet's membrane detachment in all kind of directions who are actually not obeying you. Now, having said this, even if the Descemet's doesn't get attached in the direction it should, because the scroll is trying to move in this direction, you've gone in and attached it in a different direction, where it is increasing the scroll, it actually will not matter, because what will happen eventually is that the endothelial cells from there will proliferate and will migrate the gap on a long-term basis. So, although I know that I am also very familiar about getting it right, but if you don't get it right, everybody is, because that kind of gives you mental satisfaction that, you did it the right way. But even if you don't, it doesn't matter, because endothelial cell proliferation is known and will happen in the long term and will fill in the gap if it is not too large.
Ma'am,
Yeah.
can I go ahead, ma'am?
Yeah.
So,
Yes,
ma'am, if we have a small distance detachment, maybe in the periphery, and with localized edema, do we still need to do desmetopexy there, or we can leave it?
So small, very small detachments is shallow. I think more important is the shallowness of the detachment. If it is very small and if it is shallow, you can leave it. It will spontaneously resolve. But if it is a detachment which is non-planar, which is large, even the peripheral ones, I would address them if they are large detachments and the gap is too much. By gap being too much is if it is more than 1 millimeter.
Ma'am, can I ask what?
Yeah.
It was a very wonderful presentation that intraoperatively pneumodesmetopexy you have shown, and the end point looking into the intraoperative OCT. But in absence of intraoperative OCT, what should be the end point? Where we should we feel this much is the sufficient?
Your endpoint would be the clarity of the cornea, because PSEC and DMEC have taught us one thing. Earlier, what we were doing with these Descemet's membrane detachment was that you just inject the air and you come out and that's it. So now what we are doing is we've learned two things. One is that you put it there and keep the pressure on. Take air in 10 ml syringe. So keep the pressure on and simultaneously give external massage. So you're kind of draining the fluid away, and do this for 4 or 5 minutes. On the table itself, you will see the clear cornea without having to see on the intraop OCT. This is what intraop OCT microscope has taught us, that if for 4 to 5 minutes you put a positive pressure on with the air or the gas, do external massage. That is how you get your DME grafts also stuck, or your DSEC grafts also stuck. So this is the patient's own Descemet's membrane, which is partially all attached. So here you have to make less effort, but you have to work on the same principle. So put the pressure on, positive pressure on for 4 to 5 minutes, and the external massage and the clarity on the table that it is beginning to clear. And I think you are there.
How you decide to use the air or gas? What is the indication for air and what is the indication?
If it is a superior attachment, say if it is a superior attachment and it's a planar attachment, planar means it's a simple attachment and the gap is less than 1 millimeter, I would inject air. But if it is a scrolled attachment, which, scrolls like this, And if it is a attachment which is more than 1 millimeter, that means the gap is large, then I would put SF6 or C3F8.
Thank you. Thank you.
With the help of IOCT, you can do it in the same sitting, right? Same sitting you are doing?
Suppose you detect it on the table, you can just at the end of the surgery leave air bubble there, rather than let it happen and then address it.
Hello, ma'am. Hello, ma'am.
Hi,
Vasudha, can I ask? Hello, ma'am. How are you, ma'am?
Yes, yes. Why not? Yes.
A coincidence. Just now only I see a case which was operated somewhere else on 13th of July, and they did C3F8 gas injection on 15th of July. But still, there is a persistent corneal edema. I have repeated anterior segmentosity. There is no Desmond's detachment. What should be the line of treatment now?
So if it was done on 10th, the bubble was also done on 15th, and the corneal edema is still there. And today is 5th August. So I think it has, and what is the corneal thickness? I think that is more important.
It is 1190.
It is?
1190.
My God.
Yeah.
I think this case, like I said, has maybe the endothelium itself preoperatively was also compromised. So for this case, because there's no Descemet's membrane detachment, you can't do anything in this. Suspect endothelitis, provided the patient has some vision in the immediate post-op period. But if it is not there, then for this case, you have no option but to do endothelial keratoplasty.
Yeah, today's reason also is a hand movement, and it looks like that there could be some possibility. It's not my case. He has just come for a second opinion here. It looks like that there are some complication because I could not see the red glow very well, and even the pupil is not dilated that much. And he was only using prednisolone, that too not from a good company. So probably does that hypersol or any other treatment like Ripatec will help?
Ripatec you can give. Ripatec may help, but when it becomes so chronic, more than 1,000 microns plus, then even Ripatec is unable to pump, but can be given hypersol Ripatec, at least for the symptomatic relief.
Yes. Thank you so much, ma'am. Just a coincidence that your lecture such wonderfully done as you
joined.
This patient came.
Jasni ma'am, will you like to come? We have got many postgraduates today on this panel. So your expert comments with respect to corneal edema, ma'am. Dr. Sharatini ma'am, are you there? Dr. Prashant has also joined. Dr. Siddharth Malaya, he is also one of the cornea consultants in our city. Dr. Siddharth, do you have some queries? Yes.
Yes, ma'am. I just want to ask Dr. Namrata that the cases that you have shown in post-operative period, we are suspecting herpetic endothelitis. So I do not have a lot of experience about it. So I just want to know, have we noticed KPs in these cases?
So they were not KPs in that sense, and so we did not, think that they would be herpes. So out of, you can say, in about 20 to 30% of the cases, the KPs were there. Now we have a series of almost 100 plus cases of herpetic endothelitis in the last, say, 10 or 12 years. And KPs are there in about 20% of the cases. That is why actually you don't suspect it to be, you don't think that it will be herpes endothelitis, and they were not there in rest of the 70% cases. So even without the KPs, you can have it, and if you suspect, then it kind of helps.
So like whenever you have suspected herpetic endothelitis in these cases, so maybe a course of a steroid for a week has been given and then you suspect it like that. Or at the outset only you got it that this is herpetic.
Not at the outset. That is why I'm saying, see, these patients are always, when they are referred, or even if you have your own patients, they would be always on topical steroids. that would be still going on because they've undergone a phacoemulsification surgery. And if you have such a stormy post-op course, nobody actually wants to take that off. So topical steroids would be definitely there. So all that you actually need to give in these cases when you suspect or when you would want to give a trial, I would say a trial would be to add systemic acyclovir to it. So just give acyclovir 400 milligrams 5 times a day for 21 days. Again, the dose in these cases, I think, should be remembered because people tend to give acyclovir 400 milligrams twice a day. Now, when you are, a day is a prophylactic dose. It's not a therapeutic dose. So 5 times a day is a therapeutic dose because once you're suspecting, then you hit it hard on and full on. I mean, no point giving half the dose or, giving a prophylactic dose when you are suspecting it to cure it. So give it full on completely. And also pep up the steroids, topical steroids. So if it was 4 times a day, increase it to 2 hourly. And then see how it responds.
Okay, ma'am, and thank you, ma'am. And I just want to ask one more question that increasingly we have started using ROCK inhibitors for as an anti-glaucoma medication also, and as for increasing the viability of endothelial cells in corneal edema also. So, but in sometimes it has been reported in our cornea groups also that it causes honeycomb-like epithelial edema. So, what is your experience in that?
It does cause, and it has, we again have a series of 15 plus cases where it has occurred after, not after phacoemulsification, but after endothelial keratoplasty, where when you think the DSEC graft is not, this thing, or even in cases where for glaucoma, people are using it. So that is there. So you have to stop these ROCK inhibitors in those patients. So that is a possibility.
Yeah, thank you. Thank you, ma'am.
Dr. Sharadini, ma'am, will you like to comment?
Yeah. It was a wonderful lecture. And the way Dr. Namrata has answered the question was very clear and it was easy to understand. I have 2 questions which are basically little controversial treatments for corneal edema. Dr. Namrata, have you heard about one contact lens which used to come from Hyderabad, and they used to say till you apply the lens, the vision will be clear and then you can replace.
These were, they used a hypotonic solution in those contact lenses. And they did come into the market, but they were withdrawn. I also have a slide of that, but I didn't show it because I thought since it is not available. And I did not personally use them, but I know that I don't know really people who've used them, they ever benefit from it. But the pictures that were shown by the company itself did show that, it tended to become clear, but I'm not sure. I mean, I didn't like the idea only because I thought that as it is, it's a compromised situation and then you put a contact lens causing hypoxia. I don't know how that will, interact with a compromised cornea.
And the second is doing just a desmetorexis in early corneal edema, leaving it raw and let the endothelial cells expand.
Something like a DSO, desmet.
Yeah, DSO, exactly.
That is desmet stripping without endothelial keratoplasty. So I think
yes.
In corneal edema, people have not used it. In fixed dystrophy, people have used it, and that too not for cases where surgeries have been done, at least, I mean, not in the immediate post-op period. But I don't know, maybe that has a role to play. But personally, I have not used it. Cases where I've done DVEC, also I have not found DSEC where it was indicated, DSO where it was indicated. I have not found very encouraging results. Maybe I'm not doing it correctly, or maybe the case selection is not the way it should be.
And there is one question about use of PCL in post-keratoplasty cases. Can it induce corneal edema?
So bandage contact lens will not induce edema. Bandage contact lens for post-keratoplasty cases, we generally use for persistent epithelial defects or epithelial defects. That
yes. Dr. Parmar, you want to say anything?
Yes.
Yes.
I have a question regarding the means herpetic endothelitis. What does it prevent? Actually, very recently we have seen few cases post cataract surgery they developed corneal edema within a week. Means on discharge they are having 6.6, 6.9 vision, but on first follow up, even very early follow up, within a week they present with the diffuse corneal edema. the classical cobblestone corneal edema. And we are thinking of TAS, some kind of, though there is no vigorous inflammation, anti-segment inflammation, but we left only one option, that is TAS. So is there anything else we can see for to reach on a conclusion that it is a herpetic, like some vascularization to the cornea, some footprints of the herpes in the cornea, to make it more clear that it is a herpetic endothelitis?
So that would be definitely there, and I think TAS is a completely different chapter and would require another lecture just on TAS. But yes, footprints would be there, maybe in the fellow eye, in the same eye the patient has had previous herpes.
Any questions from postgraduates or any faculty members, panelists? Any queries from this side?
Madam, if you are not having any access to ASOCT, then what is the message for them if there is very severe edema and they are not able to see the Descemet's membrane and endothelium on slit lamp? So how they clinically assess for the DM?
There's no ASOCT, and
If ASOCT is not available.
Then alternatively, you can do two things. One is you can debride the epithelium and then try to look at the slit lamp, because that kind of improves your view a little. And second is you can also put glycerine eye drops. Of course, that has to be made in a pharmacy. So that dehydrates the cornea, and again, it makes it little clear for you to be able to see what is happening at the back, whether detachment is there or not.
Thank you.
So I think all queries are clear.
Thank you so much.
Sharadini ma'am.
Thank you so much, Dr. Namrata. We always feel
Yes,
proud
it was
for
very informative. Yes.
your lecture.
Thank you so much.
Now I invite
हमेशा छा
Dr.
जाती है
Harpal. Huh?
मैडम हमेशा छा जाती है it's a good wonderful
I
lecture
think
always
she explains it in a very nice way, very simple way.
Yes.
Everybody can understand.
always she's always there but ये कि फर्स्ट टाइम इतना
Yes.
लंबा लेक्चर हमने सुना नहीं तो वो कॉन्फ्रेंस में 5 मिनट 8 मिनट 10 मिनट करती है फर्स्ट टाइम चैप्टर Thank you, madam. Thank you for wonderful talk.
Thank you so much for
Now I
having
invite Dr. Harpal Singh for our official acknowledgement.
So thank you, ma'am. On behalf of the Division Ophthalmology Society, thank you all of you for your active and interactive participation in today's masterclass Gurukul. We extend our sincere regards to our honorable guest speaker, Professor Namrata Sharma, madam, for excellent presentation on corneal edema. Thank you so much, madam, for sparing your valuable time for us.
Thank
We
you.
are grateful to you.
Thank you. It is always a pleasure to be at MPSOS. And thank you for changing the time and accommodating because of my commitments. Thanks, son. Thank you. Always.
Madam, we are part of SOS, but we are Bhopal Divisional Ophthalmic
Yes,
Society.
yes, it is on behalf of
It's
Bhopal
a small
Division.
get together. Yes, Vinita, our state scientific chairman, is from Bhopal, so she is part of us with us. But this is originally, this is started with the Bhopal Divisional Society. So we are a small.
Officially, madam, thank you for the tune. Thank you so much, madam, from MP State also. We are very happy to have you, and it was a wonderful lecture.
Thank you.
But yes, because we are having Dr. Pankaj Chaudhary from Chitrakoot, Dr. Gautam from Dr. Pankaj from Rewa and Gautam from Chitrakoot, Dr. Sharadini from Indore, and PG is also from the other places. So it is a PEN MPSOS, I should say. It is, we started with BDS, but now it is a MPSOS program. So extending to that.
Thank you so much. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, everyone. Thank you, ma'am.
Thank you, Dr.